All right, welcome everyone. Think of today as a clinical gauntlet. We're not just going to sit here and memorize a bunch of facts. No, we're here to sharpen that diagnostic reasoning, the skill that's really going to set you apart both on your exams and, more importantly, in your practice. So let's just dive right in. And this right here, this is the core principle for everything you're about to do. Look, anybody can cram a list of symptoms the night before a test, but a real diagnostician, you've got to understand the why. You see the pattern, you connect those dots, and that's how you nail the diagnosis. That's the muscle we're building today. Okay, so here's the game plan. We're going to tackle 5 classic clinical puzzles. We'll start in OB, jump over to some outpatient stuff, hit neurology and nephrology, and then we'll wrap it all up with a super high-yield review. Sound good? All right, let's jump into our first case. Picture this. It's the middle of the night, you get a page. A pregnant patient, sudden gush of fluid. Man, the clock is ticking, right? You have to make the right call, and you have to make it fast. So here's the classic setup you're going to see. 34 weeks pregnant, a sudden event, and here's the key word, the one you gotta lock onto: painless. That single word is your first and maybe your biggest clue. So what's the question on your mind? It's this. Is this a ruptured membrane or is this a bleeding placenta? I mean, both are incredibly serious, right? But they send you down completely different paths for diagnosis and management. Getting this right is absolutely critical. And let me tell you, the board exams love to test you on this exact distinction. So here's the cheat code. If that fluid is clear and the belly is soft, not tender at all, you should be thinking PROM, premature rupture of membranes. But if there's pain, if there's bleeding, and that uterus feels like a rock, tense and rigid, that, my friends, is placental abruption. It all comes down to pain. Pain is the great divider here. So you might be asking, why does PROM even happen? Well, there are a few reasons, but the number one cause, the one you absolutely have to remember for your exam, is an ascending infection from the genital tract. What happens is bacteria creep up, they release all these inflammatory chemicals, and those chemicals just weaken the tetal membranes until they pop. Yeah, the other things on this list matter, but if you remember one thing, remember infection. Okay, let's switch gears. Our next case is something you'll see every single day, whether you're in primary care or the ER. It's the patient who comes in with that just wicked sore throat. You know this patient. You've seen them 100 times. Usually a college student, high fever, just looks completely miserable. You take a peek in their throat and, whoa, you see these massive tonsils just covered in white gunk. Classic pharyngitis. But the real question is, what's causing it? And this is where we hit a fork in the road. Is this just simple strep throat, something we can knock out with some antibiotics? Or is it the great imitator, infectious mononucleosis? Because mono, which is caused by the Epstein-Barr virus, is a whole different beast. It comes with its own set of unique and pretty dangerous complications. So how in the world do you tell them apart? The throat can look identical, so you have to look bigger. The systemic findings are everything. And the single most important physical exam finding that screams mono is splenomegaly, an enlarged spleen. If you do your exam and you can feel the tip of that spleen just below the ribs, boom, your differential just got a whole lot smaller. Then, a positive monospot test and some atypical lymphocytes on the blood smear will lock in that diagnosis. And this is why it matters so much. The one thing we are terrified of with mono is splenic rupture. That spleen gets big, it gets inflamed, and it becomes super fragile. Any little bit of trauma, a fall, a hit in a game, can literally cause it to burst open. And that's a surgical emergency. So your entire management plan is built around one thing: protecting that spleen. That means no physical activity for at least 21 days and absolutely positively no contact sports for a month, maybe even longer. Okay, let's pivot again. We're going from a systemic infection to a very specific focal neurological problem. When we talk about stroke, the physical exam isn't just about saying, yep, it's a stroke. It's about being a detective. It's about localization. Your findings can tell you exactly where in the brain the lights went out. So let's look at the details here. First, the setup. Chronic hypertension. That's a huge risk factor. Second, the event is sudden. And third, and this is the real kicker, the deficit is purely sensory. The entire right side of his face and body goes numb, but his muscle strength is totally normal. He can move everything just fine. This specific presentation is a classic, super high-yield scenario for your boards. So what's actually going on here? What's the mechanism? The term is lipohyalinosis, but let's make that simple. Think about it like this. Having chronic high blood pressure is like constantly sandblasting the inside of the brain's smallest, most delicate arteries. Over time, that damage causes the walls to get thick and scarred, and eventually, one just blocks off. It's not a huge blockage. It's like a single tiny mail sorting desk in the brain's giant central post office just shuts down. And because it's so specific, you get a very precise, very clean deficit. And knowing this localization stuff is pure gold for your exams. So for our patient with that pure sensory loss on the opposite side, that's a lacunar infarct in the thalamus. Bam. Now, what if he had pure motor weakness instead? Well, the lesion would be just next door in the internal capsule. If you can master this table, if you can look at the clinical signs and pinpoint the spot in the brain, that is a next level skill. All right, next up, another presentation you're going to see all the time, the patient with flank pain. And man, the list of things it could be is long, right? But just like before, there are a few key findings that will cut through the noise and lead you straight to the right answer. And here it is, the classic triad for pyelonephritis, which is just a fancy name for a kidney infection. You've got fever, you've got nausea, and you have CVA tenderness. That's the costovertebral angle tenderness. You know, that deep, aching pain you get when you give a gentle thump on their back, right over the kidney. Okay, so we suspect it, but how do we prove it? Well, the single most specific finding on a lab test is the white blood cell cast in the urine. So what is the cast? Just think of it like a jello mold of the tiny little tubules inside the kidney. If you find one of these molds that's packed with white blood cells, that is your smoking gun. It proves, without a doubt, that the infection is inside the kidney itself. That's how you tell pyelonephritis apart from a simple bladder infection or cystitis. So let's quickly run through the things that try to trick you. What about a kidney stone? Well, that pain is usually colicky. It comes in waves, and you'll often see blood in the urine. But here's the key, usually no fever. What about pelvic inflammatory disease, PID? That's going to be pelvic pain, right? And on exam, you'll find cervical motion tenderness, not flank pain. Knowing these key distractors is absolutely essential. All right, time for our final case. And this one is probably the most subtle of all. It's a condition that often shows up late, and the symptoms are so vague that it's really, really easy to miss. So let's look at the clues. First, it's chronic. It's insidious. This has been going on for months. Second, the pain is this dull, constant ache. It's not sharp, it doesn't come and go. And third, this is the most important part. It's affecting both sides, which is why their overall kidney function is starting to decline. So what on earth could this be? The quote here really nails it. Imagine ivy growing behind a wall. It just grows slowly, silently, and it starts to squeeze the pipes that are running through that wall until nothing can get through. That is a perfect picture of retroperitoneal fibrosis. The problem isn't inside the ureters, like a kidney stone. It's a layer of thick, fibrous tissue that grows in the space behind them and literally encases them, squeezing them shut from the outside. So the thing that really separates RPF from everything else is that it's bilateral and it's chronic. A kidney stone, that's almost always one-sided and comes on suddenly. An enlarged prostate, or BPH, that causes trouble way down low, in the bladder, not this kind of backup in the kidneys. This slow, bilateral strangulation of the ureters, that's the signature move of RPF. Woo! Okay, we've gone through 5 pretty tough cases. So now, let's boil everything we just talked about down to the absolute must-know, high-yield facts for your exam. This is the rapid-fire review. You ready? Let's lock this stuff in your brain for good. I call this the rule of 1. If you forget everything else, just remember this. For PRUM, the one thing you need is a painless, clear gush of fluid. For mono, the one physical sign is splenomegaly. For that specific thalamic stroke, the one pattern is a purely sensory deficit. For pyelonephritis, the one lab finding is WBC casts in the urine. And for RPF, the one concept is bilateral obstruction. Think of these as the key pivot points. If you see one of them, it should immediately get you thinking down the right path. And that kind of brings us full circle to a final thought I want to leave you with. You know, as our diagnostic tools get more and more advanced, it's so tempting to just rely on the CT scan or the lab report. But what have we seen today? From actually putting your hands on a patient, to feel for a spleen, to truly listening and interpreting the quality of their pain, that art of physical examination, that power of clinical reasoning, that's never going to be obsolete. That is and always will be the bedrock of what makes a great physician. Thanks for joining me.